and the nitty-gritties of the same can be taught online. And this is the advantage of technology. COVID have brought a lot of havoc with us, but it has given us a technological advantage of learning pan India. I remember in our residency days, we would go and travel to Mumbai and other places to listen to esteemed faculty, esteemed teachers to take our classes. But today, more than 550 plus residents and students across India have logged in for this session to go through nitty-gritties of case presentation. At the outset, I want to thank IACM, which has been the partnering organization, which has actually delivered on various other academic fronts with us. And this time they have given their forum and participation to align with the academics and teaching. And Dr. Anil Kulshrestha, who's president of the same in the Gujarat chapter. I welcome Dr. Anil Kulshrestha firstly to the dais. Dr. Anil,
Thank you, sir.
welcome.
Thank you,
I
sir.
also am awaiting Dr. B.B. Solanki, who's Professor of Medicine from BJ Medical College, Ahmedabad, also to join. He's the secretary of the same. But with me is our esteemed faculty, Professor Soumitra Kumar from Calcutta, very loyal entity. I don't think I need to go ahead with his slides on presentation because we, of course, will have his introduction when he presents a slide, but everybody knows him. I think that slide can very well be omitted if it's there because he is an esteemed teacher, well respected and regarded across India, and very well an examiner to various universities, including the NBA exams across our country. So today we have Dr. Dikshit, my own resident at UN Mehta Institute of Cardiology. Today's session is dedicated to case presentation. So we usually have three faculties who will be doing. Dr. Anil and Dr. B.B. Solanki are doing the honors of being on the dais. They can also join if there is any discussion for the case presentation. But Dr. Soumitra Kumar is the expert of rheumatic heart and multivalvular disease. Myself, Dr. Kamal Sharma from BJ Medical College, UN Mehta Institute of Cardiology, Ahmedabad, and Professor Dr. Ajay Mahajan, Professor KEM Hospital, Mumbai, will be the three faculty where Dr. Dikshit will be presenting a case of multivalvular heart disease, a rheumatic heart disease, which is very often asked as the most common clinical case presentation, a long case. After some 50 minutes of his presentation and discussion, Dr. Soumitra Kumar is going to take us through an approach because at DM level, what we intend to look at is how do you decide a dominant lesion? Nobody is going to give you a pure MS case or a pure AR case in rheumatology as a rheumatology case in this subgroup of case presentations in DM. And for that purpose, it would be important that how do you decide which is the dominant lesion, the mitral valve or the aortic valve, the stenotic or regurgitant. That decision making is what Professor Soumitra Kumar is going to take through us. So welcome, Dr. Professor Soumitra Kumar. It's a pleasure
Thank you.
indeed to have you.
Thank you.
Thank you, sir. We've interacted through multiple conferences, including one of our own digital conference on CardioCon, where he was a faculty when he had come and presented his lecture and important topics. So, Dr. Soumitra Kumar, your few words as the esteemed guest, and then we can start with presentation.
Yeah, this is an excellent endeavor. And I think I know why nobody could organize this in the past. So congratulations to Dr. Ajay Mahajan and to you, Dr. Kamal. I mean, I'm privileged to be part of this endeavor and look forward to a very scintillating program, which should be interesting and useful for everybody who have logged into this program. And incidentally, as I was just mentioning, it happens to be Teachers' Day, so no better occasion to begin this endeavor than Teachers' Day. So greetings to everyone, teachers, students, everyone. We are all students throughout our life, and we are privileged if we are considered to be teachers. At least personally, I consider to be privileged.
Thank you very much, sir. Dr. Ajay Mahajan, sir, has joined. Mahajan, sir, good evening.
Good evening. So
Sir,
happy Teachers Day to everyone. The most important thing is the planning of this particular series. So this is taken into consideration of all the varieties of the cases which everybody faces for their DM or DNB exit examination. So most of the topics are covered, and if we regularly attend this particular series seriously, then I think 60% of their presentation part in the final examination will be taken care. They have to be very attentive for each and every session, because the most important thing will be the discussion in these cases and how the examiners ask the questions, and how the what are the answers are expected. So that will be discussed. So my hats off to you, Dr. Kamal, because you had planned this particular program very nicely. And my sincere thanks to Professor Dr. Soumitra Kumar and other faculty for their taking part in today's session. So without wasting more time, I will ask Dr. Dikshit to start case presentation, and then everybody will enjoy today's learning. Thank you.
Yes,
So
sir. Can I start my
Dr. Dikshit, you can start presentation, and I thank AstraZeneca and Nirvana for their support for this academic organization in this event. Over to Dr. Dikshit. You can say next slide whenever you're. Next slide, please.
Good evening, everyone, and happy teachers to all beloved teachers. Next, I am presenting case of 49-year-old married postmenopausal female coming from a lower socio-economical classes, housewife, religion by Hindu, residing at Nadiad, Gujarat, coming to UN Mehta Institute of Cardiology with chief complaint of breathlessness on exertion since 7 years and chest pain on exertion since 6 months. Next. On elaborating history of presenting illness, the patient was apparently well 7 years back. Then she developed a dyspnea on exertion, which is insidious in onset, progressive in nature. Initially, she used to carry out day-to-day activities and was able to climb 2 flights of stairs, which suggestive of NYHA grade 2 dyspnea. Her dyspnea progressed from NYHA grade 2 to NYHA grade 3 in last 1 year in the form of she feels breathless even in day-to-day activities and climbing 1 flight of stairs. Dyspnea is usually relieved on rest and is not associated with cough, expectoration, or seasonal variation. Patients also complained of nighttime awakening after 2 to 3 hours of sleep due to dyspnea. That used to get relieved by sitting up and roaming around. It happens since last 1 year. There is no history suggestive of orthopnea, hemoptysis, hoarseness of voice, difficulty in swallowing. Next. She also complained of chest pain on exertion since 6 months, feeling heaviness in chest, which is retrosternal, diffuse, non-radiating, initially on going to the market, which is about 1 kilometer from her house, or climbing 2 flights of stairs. And it's usually relieved on taking rest, which suggests you of NYHA grade 2 of angina. Now she develops chest pain even on day-to-day activities and walking on the ground level and climbing on 1 flight of stairs since 1 month, which suggests you of NYHA grade 3 angina. Chest pain is also associated with dyspnea. There is no history of palpitation, giddiness, syncope, limb weakness, ultrasensorium blackouts, slurring of speech, diminution of vision. There is no history of pedal edema, abdominal distension. There is no
All right.
history
So
of
Dikshit, so you have important symptoms in form of dyspnea and angina. Those are the two
Yes.
symptoms, right? So
Yes,
what are
sir.
the common causes of the combination of these two symptomatology in a patient of 49 years of age presenting with the duration that you mentioned? What are the probable differentials that come to your mind? No positive other history, right? Apart from that.
Yes, sir.
Okay.
Sir,
So what
my
are the
first,
differentials that come to your mind?
based on the symptoms, my first differential diagnosis is valvular heart disease, basically left side obstructive valvular heart disease, or based on the age, second differential diagnosis may be ischemic heart disease, or third differential diagnosis may be any other LVOT obstruction like hypertrophic cardiomyopathy, sir.
Dixit, I mean, why would you? She's postmenopausal.
Yes, sir.
She's 49 years. I don't know what about risk factors are and family history. Why would you consider ischemic heart disease or coronary artery disease as the first cause? Why would you? I mean, whosoever has lived 42 years of life asymptomatic, why would she suddenly become so symptomatic because of valvular heart disease? What valvular heart disease do you have in mind? I mean, rheumatic degenerative,
For,
or congenital?
sir, my first diagnosis is valvular heart disease
Why?
because patient has a long history of our symptomatology like dyspnea since 7 years and chest pain since 1 year. If a patient is having a ischemic heart disease, then might be patient patient deteriorates increasingly in short time period.
Would you tend to give some weightage to PND? I mean, how often do you see PND in ischemic heart disease and in valvular heart disease comparatively?
Sir, in valvular heart disease, PND is more as compared to ischemic heart disease
Why?
because basically PND is happened due to increased left atrial pressure, which lead to increased pulmonary venous hypertension, and
Can
it
it happen in HFpEF? Can it happen in LV dysfunction because of ischemic heart disease?
but if sir, a patient is complaining of dyspnea on exertion since 7 years, if
Okay, so PND is an acute pulmonary edema, or is it a chronic pulmonary edema?
it is chronic, sir.
So what does it represent? What represents what pathophysiology in the lung? What's happening in the lung?
Sir, it represents increased pulmonary capillary wedge pressure.
So that wedge can be elevated in multiple causes: pulmonary veno-occlusive, mitral. You can have pulmonary venous thromboembolism. You can have LVEDP raised and hence
But
increased wedge. It can happen in ischemic. That's not the mechanism.
patients, sir, a patient also had a history of angina.
No. So my question is it VQ mismatch? Is it alveolar edema? Is it, you should now tell,
It is, sir,
interstitial edema?
interstitial edema.
That's the point. So interstitial edema is the pathophysiology.
Okay, so you have also mentioned hypertrophic cardiomyopathy. And you will not consider dilated cardiomyopathy in this patient, ischemic and non-ischemic. Dixit,
Yes, sir.
would you consider
Can I audible,
dilated
sir?
cardiomyopathy? I did not hear about dilated cardiomyopathy. You have mentioned ischemic heart disease. I presume you have included ischemic cardiomyopathy, but wouldn't you consider idiopathic cardiomyopathy as well in this age group, 7 years? So you have see a lot of cases of people with normal coronaries having idiopathic dilated cardiomyopathy.
Yes, sir. But in majority of patients in idiopathic cardiomyopathy, angina is not as so severe as.
Yeah, that's true. But
And
Yes.
what about Dixit, what about the orthopnea? You said because it is not there. Would it be a feature with dilated cardiomyopathy?
Yes, sir. It is a orthopnea suggestive of long history of any
Yes,
cardiomyopathy.
because in 7 years of history, orthopnea still have not happened. No? It is only the PND which is there.
Yes, sir.
So would it be favoring the dilated cardiomyopathy or would it not be favoring the dilated cardiomyopathy?
Not favoring the dilated cardiomyopathy, sir.
So that
If
brings us to
patient had
the question, Dikshit, what Dr. Soumitra Kumar sir was asking. What are the conditions that will worsen a patient who was previously stable, all of a sudden in a valvular heart disease to become unstable? What are the
sir,
possible etiologies?
it may be due to arrhythmia or it may be due to underlying infection etiology
Infection as in where? Urinary tract
or
infection, lower respiratory tract, what?
lower
Any
respiratory tract
infection
infection,
or
any LRTA or sir, it
which
may
infection in a valvular heart disease is the most dangerous infection and will worsen the patient most?
a lower respiratory tract infection, sir.
No.
No, talk of an infection directly on the valves.
Infective
Infective endocarditis.
endocarditis.
So don't be
Yes,
misled. Infective endocarditis or rheumatic carditis, right? So that's how you remember.
yes.
Rheumatic carditis, infective endocarditis, anemia, atrial fibrillation, worsening of regurgitation, pregnancy, those things, you know all of them, but when it comes to be asked in a twisted fashion, you don't answer it. Same way, you always know that it is interstitial. That's the whole idea of making you present in a case, because you know the answers, but when you are asked in a twisted fashion, you're not able to answer it. Sir, you were
Do you
saying.
get any auscultatory findings in interstitial edema? Or when you auscultate the lung fields? Do you get any findings?
Yes, sir.
Dixit?
Yes,
Huh?
sir. Yes,
You
sir.
do?
Rails. Crepitation is
You
there.
do? If it is interstitial, how are you going to hear creps? I mean, a lot of our residents tell me, doctor, sir, this patient has come with breathlessness. I can't hear in looks like non-cardiac. And on the other hand, if you hear coarse crepitations, but patient is comfortable, what is the other probable diagnosis? Not in this patient, of course.
It may be due to lung pathology, sir.
Yes, of course. So remember that you may not be able to hear anything on auscultation on the lungs. Okay. Okay.
Alveolar edema will lead to the crepitations. Interstitial edema will not lead to any crepitations.
Okay. Yes, sir.
Go to next
So
slide.
no history of fever, huh? At any point.
Yeah.
Dixit?
No, sir. No, sir.
So no history suggestive of fever or joint pain. So no rheumatic resurgence or infective endocarditis in this patient.
Yes, sir.
Suddenly at 42 years, there is a onset of symptoms.
Can
Yes,
it be a congenital heart disease?
sir, it may be in patients of bicuspid aortic valve, there is a late presentation of valvular heart disease.
Is the sequence of symptoms in keeping with bicuspid aortic valve? That angina for only 6 months and dyspnea for 7 years.
Sir, basically, dyspnea NYHA grade 2 can happen in the congenital heart disease.
No, what is the usual sequence? Of course, individual variations can occur. What is the usual sequence of symptoms in a case of bicuspid aortic valve?
Sir, first angina, then syncope, and then dyspnea.
So, it has been more or less a kind of a dictum that anyone with dyspnea with kind of severe aortic stenosis, the expected survival is not more than 2 years. Now it is 7 years. So how strong is your diagnosis of a possibility of bicuspid aortic valve in this patient?
Can it be congenital corrected transmission of great artery?
Yes, sir, it can be. But angina is not there, sir.
Angina, can it happen in congenital transposition? Congenitally corrected transposition, great artery. Can you get angina?
If it is associated with, sir, coronary artery disease or
No
something
disease.
else.
No disease, then coronaries are angiography is normal. And let's assume that they are not even anomalous, not crossing the RVOT, not between the great arteries, not malignant course. Can you still get angina?
What is the natural history of congenital corrected transposition? What happens to the systemic ventricle, which is right-sided ventricle? Anatomical right ventricle, if it goes to the systemic ventricle, what happens?
RV, sir, pressure overload is there. So right ventricular hypertrophy is there.
So, ischemia?
So can single right coronary artery is sufficient to give the blood
Supply.
circulation to the systemic ventricle?
So that's a demand supply mismatch, right? What type of ischemia is that called? Type 1, type 2, type 3.
Type 2.
And can you get angina? Same logic in a patient with isolated mitral stenosis, severe MS. Can
Yes,
he
sir.
present with it?
Yes, sir. Due to severe PH, it can lead to RVH and it can cause RV angina
Or
or associated with any coronary artery disease
or
or
suppose he has
dilatation
an
of
atrial fibrillation and his heart rate is ventricular rate is 150. Can he get angina?
Yes, sir. Due to tachycardia, patient has a less diastolic feeling, so
Absolutely.
forward flow is less. Or it may be due to dilatation of pulmonary artery, which can compress the coronaries also.
That's rare, but yeah, that also. So AF, an emboli? Can you throw emboli to coronary? Haven't you seen?
Yes, sir.
Haven't you
Yes, sir.
washed up in patients who have MS and have come with a clot in the coronary? Thrombosuction done, no angioplasty needed,
No, sir, I have
right?
not seen.
So coronary emboli can also happen. So these are
Yes.
multiple things that can happen. So can we move to the next slide? I think, Dr.
Yes.
Soumitra Kumar, any other
Yes,
question you
yes,
want to ask?
perfect. I think let's proceed. Yeah.
Yeah. Dikshit?
The past history, before 3 months ago, patient was consulted to general practitioner, was told to have some heart disease, which needs a surgery and advice for some oral medicines. And there is a no history of joint pain, resist, fever, involuntary movements in childhood. There is no history of any previous hospital admission or receiving any IV drugs in the past. And there is a no history of diabetic, hypertension, ischemic heart disease, hypothyroid disorder, or any CNS disorder,
Okay.
tubercular.
Why is
in the
this
past.
important of injections or drug history important in a patient of cardiovascular disorder?
Sir, in many cardiovascular disease patient have to told to take some injection every 21 days, which suggests you of some rheumatic valve involvement.
Okay, so that is a classical teaching. I have been teaching that in undergrad. 21 days, if you're given some white color negative test dose, then probably penicillin. But unfortunately, fortunately, now things have changed. Tell me more injections in cardiology that can be given twice a week, once a week, once in 3 months, once in 6 months. Cardiac drugs, huh? Non-cardiac drugs, no.
Sir,
I know we can talk about a lot of cardiac drugs that can be given over a long duration, including the
anti-lipidemic drug
latest and
like
the costliest.
anti-lipidemic drug like inclisiran can be given
Okay,
as a
earlier
3 month or 6
shorter,
month.
that is 3 months, 6 months, shorter history. Patient says, I've been taking every 15 days, 20 days.
Why the other version of inclisiran? Are you forgetting that? The previous version, PCSK9.
Evolocumab, sir.
Why have you mentioned IV drugs? What is in your mind?
Why IV drugs?
Sir,
You mean drug addiction or something?
no, sir, no, sir.
Then
Why is it important? What are you trying to rule out with IV drugs?
Sir, it basically rules out not having any significant hospital admission, which requires urgent intention for this illness.
So IV diuretics, and then you can actually, so a good student versus, differentiating an average student is to lead the examiner. You say, so to rule out worsening of heart failure. That's a clinical term. Then the examiner jumps onto it. Okay, define it. Does it mean always hospitalization? Then if you know, you lead the examiner. No, sir. Even IV diuretics given in emergency department is a way of defining worsening heart failure. Then examiner can ask you, okay, is it always IV? Then you say, no, sir. Stepping up of oral is also considered. So that's the trick, Dikshit. You know all this, but when it comes to exam, either examiner leads you, like Dr. Mahajan asked you, CCTGA, and you get led by it, or you talk about when you're given, Dr. Soumitra Kumar is asking IV, you actually talk and drag us to that side. That's the whole trick of Viva.
Yes.
So IV diuretics, and why are you forgetting IV antibiotics?
Yes, sir. It including IV antibiotics, IV diuretics, IV anticoagulant like in heparin.
Okay, I think you can move on to the next slide if everyone
So
agrees.
IV antibiotics are meant for infective endocarditis. That is important because somebody may have received IV antibiotics for continuous 21
So
days,
that
right?
will explain your exacerbation of symptoms so late in the life. Okay.
Sorry, sir. Sorry, sir.
That will explain why she has become symptomatic over last 6-7 years,
Right.
isn't it? You have to give some explanation because I am to ask you. I mean, I can see your slide. I am going to ask you. Okay, you read the slide. I'm going to ask you.
Go ahead.
I'm not
Dixit,
able
go
to
on.
understand your question, sir.
No, sir is saying you need to explain, Dikshit, as to why
Yes,
the
sir.
patient worsened.
Anyway, I'll ask you. I can
Sir,
see the slide. That's why I'm asking. She had one vaginal delivery, successful vaginal delivery. What was
When
her
was
age?
that?
You haven't mentioned the age, approximate age when she had
Four-
that.
14, sir, her child is approximately 23-year-old.
23.
So,
So that means she was 24 years old at that point.
yes, sir, 26, 25, yeah, 26, sir.
So did you inquire about, so the both the pregnancy and delivery were absolutely uncomplicated, uneventful?
Yes, sir.
Okay. So what kind of valvular heart disease do you have in mind, Dixit, when she now has so, I mean, severe symptoms and she was absolutely asymptomatic 23 years back or 24 years back?
Sir, it can be severe MS or severe any regurgitation lesion like severe MR, severe AR.
Yeah, I accept your later point. Severe MR, AR, if they were mild to moderate at that point,
Yes,
and
sir.
if it has progressed, I can agree. But mitral stenosis, well, I mean, we have seen cases, not that I would disagree, but is it the common presentation with severe mitral stenosis patient? I mean, what is the highest incidence age group with the highest incidence of rheumatic fever or rheumatic valvulitis?
Rheumatic fever happen between 5 to 15 years of age.
So she was already 24, 25 when she had the pregnancy. So mitral stenosis, if it is there now, must have been there in some form at that point. Do you agree or disagree?
Ye agree, sir.
So would you expect absolutely uneventful pregnancy? And I mean, I don't know whether anybody has, I mean, put the stethoscope on her precordium to find out whether they have auscultated any murmur or not. So
Yes, sir.
she had an institutional delivery. Very importantly, you have mentioned it was not a
Yes, sir.
home delivery. So even the
Institution.
anesthetist puts the stetho on the chest. Okay, although it was a vaginal delivery, not a cesarean section, I agree. So surprising that anyone with suspected mitral stenosis, I don't know what is your final diagnosis, but undetected, asymptomatic till she is 42 years old, or she is 49 now. Yes, 42 years old. Any
Yes.
questions from my esteemed colleagues?
Yes, sir, fantastic. So, Dikshit, what, because sir is asking about pregnancy, disorders which don't worsen in pregnancy. Let me ask you the other way around. Cardiac disorders and patients remain. Sir has already asked about MR. Which other disorder
Any regurgitation lesions, sir, it cannot be worsened during pregnancy.
or the one that will improve? May improve,
Maybe,
not
sir,
actually improve.
AR may be improved during pregnancy. During pregnancy, there is a tachycardia, a physiological tachycardia.
Okay,
It can
tell me
improve.
conditions where the LV cavity becomes larger, so the condition improves. Now, indirect way of asking you the which conditions the murmur decreases when the LV becomes larger,
HCM, sir. Hypertrophic
and
cardiomyopathy, sir.
and
MVP, sir.
that's those that was so every time we don't have to ask you. The examiner will ask you same question in a twisted fashion. This is I often give an example of tetralogy and cardiomegaly, tetralogy with heart failure, tetralogy with raised JVP, tetralogy with answer is same. You may be asked different ways. So I'm just leaving that clue for congenital case whenever we do. But this is how it will be, Dikshit. So again, the same question can be formulated in a different fashion and asked. Of course, you'll be asked what are the conditions where pregnancy is completely contraindicated. So then you
Yes,
know. So how do you classify by WHO those conditions? What is the classification? A, B, C,
pregnancy, it
D?
may be considered. WHO one may be considered. Pregnancy may
Correct.
be considered. WHO classification 2 pregnancy risk benefit ratio is same, and WHO classification 3 is pregnancy must not be
So exactly, you
continued.
know whole classification, but when it comes to practical Viva questions, this is how you are not able to grasp. That's the whole idea. Sir, Srivar Singh.
Dixit, wouldn't you mention any of the risk factors like diabetes, hypertension in personal history? It's missing.
I have mentioned in past history, sir.
Was it there? Can you go back one slide?
No,
It's not past history, it is present also. Why would you mention it in no other comorbidities. I don't know what you meant by that. Anyway,
Sir,
it is
I
commonplace
told
to mention about the common risk factors at least. You have mentioned about addictions, I could see, but no mention of diabetes, hypertension. What importance has it got in this case? Next slide, please. You come back, go back to the, yeah. So is it important to inquire about diabetes? She's 49 postmenopausal. What happens to postmenopausal women?
yes, sir.
When
I
did
have
he have
told
the
that,
menopause? How many years back?
sir, 3 years.
3 years. So
Yes,
three
sir.
years after menopause, although the symptoms started before menopause, but there is an exacerbation in recent times. So is it important to inquire about diabetes, hypertension?
Yes, sir. It is important, sir.
Why?
Sir, majority of the risk factor like diabetic hypertension patient have high risk of ischemic heart disease.
Ischemic heart disease, yes, they are vulnerable to HPF. Okay.
Yes, sir. Yes,
And,
also.
and, and, and a combination of HPF and coronary artery disease. So we see so many patients of diabetic ladies becoming very symptomatic after menopause, isn't it?
Yes, sir.
So that is conspicuous by, so you should at least mention the important risk factors. Okay.
Yes.
In
Okay.
summary, you have not mentioned anywhere. So summarize, then we'll ask you the question.
49-year-old female presented with NYHA grade 3 dyspnea since 1 year associated with PND and Canadian class 3 angina grade 3 since 1 month.
So you see,
Can I?
Dikshit, you have mentioned angina in NYHA grading in during your presentation. Now we suddenly switch over to CCS. Any specific reason, or is it a typo?
No, sir. Type mistakes. Typing error, sir.
So stick to summary, as it's just like writing a research paper. Your abstract and the main manuscript cannot be different. Both have
Yes,
to
sir.
be same. Okay. So why
Sorry,
you
sir.
have not mentioned word rheumatic anywhere? Any specific reason in your differential?
No, sir. It may be rheumatic or congenital also, sir.
No, so severe MSAS, you think the likelihood of congenital MSAS is how much?
No, sir. Not congenital MS. Congenital.
That's what I mean. So first differential, when you're mentioning multivalvular, the commonest etiology is what?
Rheumatic. Yes, sir.
Absolutely. So that word
Rheumatic.
should come, probably rheumatic. Then our question will come, how do you know? There is no history of migratory polyarthritis, no penicillin prophylaxis. Why do you think it is rheumatic? Then you'll have to say it's still the most common cause. 50% may be asymptomatic for any history of polyarthralgia or childhood, right?
Yes,
Then
sir.
long
50%.
history, no presence of risk factor. Why it's the likelihood, the commonest disorder of a multivalvular or a patient with this kind of a symptom is, and then of course you'll have to keep differentials, what sir was mentioning. Okay, so
Yes,
every
sir.
time you have a differential put, the first differential is the commonest one. The commonality causes to make you think that a 49-year-old female with 7 years is 1 year history, or with multivalvular etiology probably, then it has to be rheumatic. Okay,
Yes, sir.
so shall we move to exam?
Yes, I think time is running out,
Yeah.
so we have to.
Dikshit, quickly, just go through anything positive in general, else you move to the next slide and come to systemic exam. Anything positive?
Yes, sir. The
Yes, go ahead.
pulse is 84 beats per minute in right radial artery, regular rhythm, low volume, slow rising, late peaking, and no vessel wall thickening, no radio-radial or radio-femoral delay, and all peripheral pulses are well palpable. Bilateral carotid thrill is present. Blood pressure
Yeah,
is
just a minute. I mean, going back to the pulse. Were you expecting sinus rhythm or some abnormal rhythm in this patient?
sinus rhythm, sir. Regular sinus rhythm, sir.
So that met your expectations. You were satisfied. I mean, satisfied in the sense that you would be able to, cope up with your diagnosis, final diagnosis. So if you said that although the
Yes,
valvular
yes, sir.
lesions, you were thinking of MS or AS. I mean, MS, which has become symptomatic at 49 years, are you expecting sinus rhythm or atrial fibrillation?
Sir, can be there in sinus rhythm, sir. Majority of patients.
Yes, definitely they can be in sinus rhythm, but what is commonplace? I mean, people who become very symptomatic, and I mean, at least atrial fibrillation onset can make the patient symptomatic, which has happened in this patient, isn't it?
Yes, sir. Arrhythmia is most likely precipitating factor for symptoms.
Okay, so this low volume, slow rising, late peaking, what is in your mind?
Sir,
Which
it
which
may be
artery you examine to find out these
left,
characteristics?
left side obstructive lesion, sir. Likely
No,
AS,
no, I
sir.
mean which artery you palpated to find out this characteristic?
Sir, carotid artery, sir.
Mm. I mean, anyway, so what have you have aortic stenosis in your mind?
Yes, sir.
Okay, carry on.
Sir, bilateral carotid thrill is present. Blood pressure is 112 by 74 millimeter of mercury in both upper limbs and 132 by 88 millimeter of mercury in both lower limbs. Respiratory rate is 18 per minute, regular thoracoabdominal. JVP is 3 centimeter above sternal angle at 45 degree of inclination with
So
normal
normal or raised?
respiratory. Normal, sir.
Okay. And as sir was saying, carotid, why do you suppose it was not aortic stenosis? Will you still look at carotid?
Yes, sir. Best for pulse characteristic carotid artery is best, sir.
Why?
Now, patient also
Why?
has carotid thrill.
Sorry.
Patient you have mentioned also has carotid thrill.
Yes, sir. Yes, sir. It reflects the central pressure, central pulse.
Not only central pulse, it's closer to the heart with a delay of 30 milliseconds, and that's why you can time it, your cardiac events from there. So we all remember ourselves the way I examine a patient murmur. I do it by keeping my thumb on the carotid and putting my stetho on the chest. Whatever is timing with it is systolic and diastolic. That's the classical learning. And that's how you actually end up palpating carotid. And moreover, as you said, some of the pulses are best felt, which are not best felt in carotid. Which pulses you need to look somewhere else? Which are those pulses?
Pulsus bispherians, sir, which is based on
Bispherians is actually
in
look no. Bispherians is well felt in
Variance is
carotid.
best palpated in carotids.
Yes. Which pulse you examine like this?
water hammer pulse
Where?
Yes.
in brachial artery, sir.
Radial. And what do you palpate in femoral? What you
Uh,
do from femoral is what you palpate in femoral. What do you do in femoral?
Durosius sign, sir.
Not results.
No,
What
no, I
pulse?
mean, yes.
Type of
What
pulse?
about the delay?
Radiofemoral delay.
And any kind of a type of pulse that is best felt in femoral, which is felt in one of the procedures. That procedure does that, create that pulse. And that procedure can only be done from femoral, not from the radial. IBP, which pulse do you get in IBP?
Yes, sir.
Dicrotic pulse. You augment the dicrotic, right? So
Yes, sir.
dicrotic pulse are better perceived in the distal pulse. That's where you have a low diastolic. Diastolic shock is when you feel the dicrotic pulse. It's because of dilated peripheries, rapid distal runoff, sometimes along with a diastolic shock. I mean, with the cardiogenic shock, low output state with a dilated periphery, like you find in enteric fever, typhoid, septic shock. And of course, therapeutically, because you inflate the balloon in diastole, you'll get a second notch in the dicrotic pulse in a patient with IBP. So remember like that.
Dixit,
Okay.
your JVP is pressure is normal.
Yes, sir.
You haven't mentioned the waveforms. All the waveforms were normal. Always mention the waveforms. JVP always mention the pressure and the waveforms. What about the waveforms?
Normal waveform, sir.
But you haven't mentioned that. I mean, you may be right, you may be wrong, but you have to mention something.
Okay.
You can have a normal. Can you have a normal pulse with abnormal waveforms? Normal pressure with abnormal waveforms?
Yes, you can, right? You can have either ways. Anything can be there. 6 points of exam, Dikshit. Anything can be
Yes, sir.
there. So you have either raised JVP, normal waveforms, low JVP, abnormal waveforms, prominent A, prominent Y, descent, tamponade, what is the JVP? Maybe high constriction, maybe high. Given diuretics, only Y descent. If I'll
Yes,
ask
sir.
you causes, you'll just start speaking it up. But that's the logic that you need to know, that 6 points of JVP examination are important. What are those 6 points of examination in JVP?
Sir, first one is the
Pressure,
height of the
so pressure.
JVP,
Second,
waveform of the JVP,
okay,
respiratory variation associated with
okay,
it, any postural variation,
very good.
abdominal jugular reflex,
And
and
pulsatility. So pulsatility,
pulsatility.
W. So
Yes, sir.
those are the things. Those are the things that everything has to come. No, second point. That's what you missed out.
Yes, sir.
Okay, systemic exam quickly. Anything positive?
No, sir.
This
Apex
is this
impulse.
is a female patient. Could you actually see the apical impulse, Dixit?
Yes, sir.
Or
Yes,
is
sir.
it
No, sir. Yes, sir. I have examined these patients.
okay? Hey, if
Okay.
you have she was a thin built lady. You said build was normal. It's not very common to see the apex in female patients. Anyway,
I have
I
examined
just
this.
thought I would corroborate on that point. So be very careful when you just don't make it a matter of habit of scribbling down
Yes, yes,
something. You must be able to explain. Okay.
yes, sir.
Dixit,
Okay. So apex
what
was visible.
about the upper limb, lower limb blood pressure difference?
Sir, it is
Just go back to
about
the previous slide.
it is about 20 millimeter of mercury in systolic and 14 millimeter of diastolic. Sir, it is maybe due to peripheral augmentation of the systolic blood pressure.
It's normal or abnormal? Dixit, I'm asking, it's abnormal or abnormal?
Normal, sir. Normal, sir.
Okay.
Okay, proceed. So I think you can skip the next slide also. I had to ask only
Next.
that. More
Next.
important is the palpation. You go to that.
Go. Next slide. Yeah.
Sir, apex beat is palpable in left fifth intercostal space at midclavicular line, localized, heaving in character. And there is a grade 2 parasternal heave present in left fourth, fifth intercostal space. And there is a presence of systolic thrill at right second intercostal space. And bilateral carotid palpable with presence of the carotid thrill.
So Dixit, my question with a grade 2 parasternal heave, you did not find any abnormal waveform in the JVP. So what do you think of that?
Sir, it may be possible to see a parasternal without elevation of JVP. Sir.
No, I accept your normal pressure, but waveform is normal and you are finding a grade 2 parasternal heave. Is it, can you explain that? Well,
Sir,
what does it mean, grade 2 parasternal heave?
It may be due to either right ventricular hypertrophy or left atrial enlargement, sir.
I mean, you don't get a heave. So is this heave mid systolic or late systolic?
Sir, it is late systolic, sir.
Is this heave is late systolic?
Yes, sir.
That you mean that is because of the left atrium?
No, sir. It can be occur in LA enlargement or right ventricular hypertrophy, but in my
No,
case,
we are
it may
all
be
aware that left parasternal impulses can be because of the RV or because of some distant thing happening in the left atrium. Okay, so sudden left atrial expansion, which happens in severe MR. That's all right. But you have specifically mentioned the word heave. Heave means a pressure overload, isn't it?
Yes, sir.
So if you have a pressure overload on the right side of the heart, there has to be something happening to the right atrium. Okay, and anyway, this heave we cannot take lightly. You will have to give us some explanation.
Yes. So Dikshit, remember important point. You cannot contradict your own findings. This is what I say. If you say there is PAH, then you'll have to speak and corroborate PAH. If you say PAH and you are trying to say PAH, parasternal heave is PAH, then you cannot say P2 is soft. Then you cannot say JVP A wave is not present. If it is sinus rhythm, that is. Or if the patient is in AFib, you must commit that you're not able to see A waves or A waves are absent, because there is no way in a patient with AFib, the A waves are going to be demonstrable to even Albert Einstein, even if he was to come with any machine. So this is pretty clear that you have to corroborate whatever strong findings you have. At least don't contradict your own findings. Okay. If you're saying LA is the late MR LA that you're getting, then it has to be a dominant MR. So this is the whole talk that Professor Soumitra Kumar is going to take. So you got what sir is saying, Dikshit?
Yes, sir.
Yes.
I mentioned the cause of parasternal leave, sir. Why it
So
is
grade,
happened?
so you said grade 2 late parasternal, late systolic parasternal heave. So which means
Yes,
either
sir.
PH. If you are saying late, then it is MR. If no PH, it cannot be MS. MS cannot give rise to a P, parasternal
Yes.
heave. That is what it means.
But sir,
Okay,
it
proceed.
MS with moderate या फिर
PH.
mild or moderate pulmonary arterial
No, mild
hypertension.
pH will not give rise to heave. Grade 2 heave, grade 2 heave means moderate pH,
Yes, sir.
right? If you have heave, pH
If you
is
have
significant.
pH is at least moderate, okay,
Yes.
moderate to
Yes, sir.
severe. You can't
So
have a
let's
heave
corroborate
otherwise.
that on your auscultation now. Okay. So go to
Okay,
next slide.
so you have carotid trill, you have a systolic trill at right and epicocarotid delay. So what are all these pointing towards? LV outflow tract, specifically a
Yes, sir.
valvular obstruction, isn't it?
Yes, sir.
Okay, but the only contradictory thing is the grade 2 parasternal heave. How do you
Parasternal.
explain that with aortic stenosis? Is it common to have it?
No, sir. In late stages of aortic stenosis, we can find a grade 2 parasternal
Late
leave.
stage, I
But
mean, people don't survive with dyspnea more than 2 years, let alone having a pulmonary hypertension and parasternal heave. Okay, people don't live that long. If you have some mitral valve lesion, then you can have it, isn't it?
yes, sir. It can associated with mitral valve disease.
Anyway, proceed. I think
On
it is not
percussion,
very important. It is, you have mentioned it. I wouldn't have minded if you have skipped it. Anyway,
yes,
good to keep a
Right.
practice
So
of
only
this.
only thing that probably percussion matters is the right fifth
second
intercostal midclavicular in the upper border, because that
Sure.
establishes situs solitus. And what
titus
Dr.
solid.
Ajay Majan was saying, a CCTGA and a situs inversus is ruled out. So that's why the right upper border is important. And then the left border with the PAH findings, the three that it's dull, second left intercostal dull or not. Otherwise, of course, tamponade and effusion if you're suspecting. Otherwise, it doesn't matter. Percussion, auscultation. Next slide.
Next slide.
Next,
Yeah.
auscultation. On auscultation, S1 is loud, sir. S2 narrow split. No S3, S4.
S2 narrow split, wait. I mean, it's a physiologic split, huh? Only in inspiration.
No, sir. It's not physiological. It may be due to delay closure of A2R.
Oh, so narrow means what? You have only three types: normal split,
Yes, sir.
reverse
Wide.
split, wide and fixed. There is nothing like, so either you have narrow split means it is narrow but still
Nor,
splitting normally, or is it paradoxical?
normally, sir. Normally, sir.
Then
Splitting
you don't
normal.
call it
So it's
narrow.
a physiologic split, but the splitting is, in your opinion, it is narrow. What about the two components you haven't mentioned, A2 and P2? Which,
Sir,
I
I
mean,
have
P2 is loud or
which one
P2 is
is
loud or
louder?
none of them?
none of them, sir.
What?
It is same intensity, sir.
No, A2 is present, audible.
A2 is audible or P2 is also audible.
P2
So
and
you
A2 are
don't
of the
have an
same
aortic valve
intensity.
disease.
Sorry.
Dixit,
Yeah.
P2 and A2 are of the same intensity.
So slightly, I can not appreciable. Slightly, A2 is compared to P2 is less intensity, low intensity, sir.
So Dikshit, if again, same thing coming to what you corroborate is what you stick to. You are going to speak what? Aortic stenosis? Yes or no?
Yes, sir.
So how are you expecting a calcified aortic valve to close and produce a sound? Are you going to talk about supravalvular AS or are you going to talk about
Va
subaortic stenosis? Then you can
valvular
say
AS,
A2
sir.
is normal. So if
Valvular
valvular
as
yes,
but
the aortic
calcified.
valve will not produce a sound because it's calcified, highly mobile, thickened. That is what you write in echo reports. So what will happen to A2? It will be soft or inaudible. And are you
Oh,
going to speak PAH?
no, sir. I can,
Patient does not have any PAH?
sir, moderate pH, but loud P2 I could
No,
not
no.
appreciable, sir.
No. So again, how can you have a PH? So P2 becomes audible or loud when RVSP is more than 50. If you say pH of 50 plus, which is moderate by definition, then P2 has to be loud. The first finding that appears in a PH patient is loud P2. Then becomes P2 palpable, then gets the heave, and then you can say I could or could not appreciate the A waves. But first finding of PAH, otherwise in a pliable pulmonary valve, is loud P2. You cannot have pH but no loud P2 in even mild pH. Dr. Sumitra Kumar, comments on that?
Absolutely agree. So, I mean, you first of all, you haven't even mentioned about the relative intensities of A2 P2, which is not acceptable. And I mean, how can you have a grade 2 parasternal heave with a normal P2? Okay, so that you have to account for. So this narrow split is because of a delayed A2 or a earlier P2?
Delayed A2, sir.
Acha.
It
So
should be both.
if
It
A2
should be
gets
both.
late,
It should be both.
it can be both.
Okay, so no S3, S4.
So
Yes, sir.
Dikshit,
Again,
in a patient of aortic stenosis, what is the classical finding that you get of splitting? What split do you get?
Narrow split, either normal narrow split or paradoxical split.
Absolutely, paradox. Remember AS pacing and LBBB. Nothing but paradoxical. If you're not getting paradoxical, something else is happening. Severe
so
AS, sir.
yes, yes. No. I mean, it becomes narrow, then becomes single, then becomes paradoxical. So it proceeds to these stages. Okay. So A2 coincides with P2, and with progressive severity it goes beyond P2. That is
Right.
the way it goes. Okay. Anyway,
Yes.
coming to your, since we are running out of time, really, no S3,
Absolutely.
S4. So you have to, no.
Come to the murmurs. Come to the
This is the
murmurs.
most
Yeah.
important part of your presentation.
The murmurs now.
No
Dikshit.
S3, S4. I mean,
Yes, sir.
okay, S3, I mean, all your findings are in favor of AS so far, but no S4. Any explanation?
Sir, it signifies that there is a obstruction at the level of a mitral valve, sir.
So
May
far,
be present.
I
It may
mean,
be
okay,
present. MS
PND
may be
was
present.
there, some pulmonary hypertension is there, at least by the parasternal heave. But apart from the heave, we don't have a palpable P2, we don't have a loud P2, and we don't have a
Yes, sir.
prominent A wave in the JVP. So no other features of PAs that we have found, only
Yes, sir.
parasternal heave.
Yes, sir.
Remember that, okay? Okay, so your next statement is very important. Opening snap present and with long
With
S2OS.
Yes, sir.
So patient having history of PND, are you expecting a long S2OS?
Sir, it may happen in the multivalvular heart disease. If a patient having a significant aortic stenosis, then LVDP raised, it can
Is opening snap common with a combination of MS and AS? First question.
opening snap depending
Yeah, it
upon the
depends
valve
on the degree of
morphology.
calcification, that I agree.
Yes, sir.
But you are now hinting at a combination of MS and AS, am I right?
Yes, sir.
So is OS common in a combination of MS and AS, rheumatic?
Yes, sir.
No, it is not common. So you should be able to explain why it is not common. Are you expecting in the face of a very hypertrophied LV with a LVOT obstruction, the valve will open with a snap?
Sorry.
It's not likely, na? Anyway,
It's
that brings
mainly
us to the next question. You go
okay.
proceed. Yeah.
Uh,
So what?
there is a
So now, since you have mentioned MS and AS, how does
yes, sir.
MS affect AS and how does AS affect MS in a combination of valvular lesions?
Sir, in severe AS, there is a increase of LVDP, which can decrease the transmitral gradient. So maybe
So we are
the
looking at a low flow, low gradient MS.
yes, sir. Yes, sir. So maybe
And
it
just now you said you are expecting an opening snap.
symptoms of the MS are worsen, but there is a gradient and a clinical finding may be masked by the severity of AS, sir.
And what happens to the AS? How does MS affects AS?
Sir, generally, if MS is so severe that there is a low cardiac output, then patient is presenting with low flow, low gradient AS.
So low flow, low gradient
Paradoxical,
AS, but your findings so far, we have got a carotid thrill, we have now got a grade 4, you had a systolic thrill, so grade 4/6
but
murmur.
sir,
Are all
I
this
think AS is so severe and MS is moderate to severe, sir. Moderate, I think.
moderate?
MS is not masking the sir, severity of aortic stenosis. In
So,
my case, sir.
okay, so
Because of all clinical examination finding are not consistent with severe MS, sir.
Okay. So basically you are saying, so come to your diagnosis. What have you brought this? And then we'll ask you why to your diagnosis. Next slide. Next slide.
Next,
Okay, other systems are normal.
next,
For the sake of time, we'll skip quickly. It's
yes,
important, but
next.
let's move. Yeah.
Sir, my probable diagnosis is acquired valvular heart disease of rheumatic etiology with severe aortic stenosis and moderate MS with a moderate PAH and moderate PVH in NYHA class
you haven't
3 in
mentioned PH, you have only mentioned PVH.
So you have typographically omitted, let's assume. So PVH and PH both are, they are moderate. Is that
yes, sir. Moderate
okay?
PVH and PVH in NYHA class 3 in sinus rhythm without evidence of infective endocarditis, congestive heart failure, or active rheumatic carditis, sir.
Okay. So why do you say it's severe AS? Number one.
Sir, there is a heaving type of apex with
So
bilateral
any
carotid
severity
thrill
starts
with
from symptoms. This is
yes,
an
sir.
undergrad question. Whenever you are asked, always start my MBBS. I'm just giving not my any. I mean, this is how it started
Always
for me.
start with
MS. I
symptoms.
said age, gender, family history. So that's how you start. Is there anything in age? So leave it. If it's not there, fine. That's how it starts. So symptoms.
Symptoms can be there, sir. Angina,
So this patient,
patient develop. Yes, sir.
this
Angina since
patient.
1 year and it. Sorry.
So patient has class 3 angina.
Yes,
That's
sir.
one. Okay. Then syncope.
Then so JVP is a normal, sir, with low rising, low
That
volume,
doesn't favor. Anything else favors AS. Pulse,
pulse, sir. Low volume, late peaking,
character,
slow rising. Yes, sir.
anacrotic,
Yes, sir. Anacrotic, sir.
Parvacet tardus.
or parvacid.
Okay, so that was the only classical thing, but thrill and the intensity of murmur, you did not mention about anything about the quality of the murmur. Was it a ejection systolic
Arch,
late peaking murmur?
mid systolic, sir. Late peaking,
It was
arching
a mid
quality.
systolic peaking or late systolic peaking?
Late systolic peaking, sir. Starting as a mid systole and late peaking murmur.
Hmm. So what points were against your diagnosis of severe AS? What were missing? First of all, your second heart sound,
Yes,
isn't it?
sir.
And
Soft
then S4 you explained on the basis of MS. Okay, we
MS.
accept that. But your second heart sound also, I mean, because you have mentioned about pH, You have mentioned about a severe AS, and now you say there is a narrow split. Can you explain that?
There in
The more severe the MS, the A2 gets more delayed, right, Dikshit?
yes, sir.
Why moderate MS PVH? PVH, why are you saying moderate? A class 3? Moderate
Because
PVH? Why?
patient is having of PND, sir.
PND is an
Moderate PVH.
episodic thing. What about the chronic PVH? So your
Patient,
grade 3 NOIJ grade 3 breathlessness, isn't it?
yes, sir.
And why moderate PAH?
Because patient is
Unfortunately,
having, sir,
accept.
grade grade 2 parasternal leave, sir.
Oh,
So you'll have to.
but then we have so many things missing. P2 is not, I mean, the JVP is normal waveform. Then there is no palpable loud second out sound P2. So,
But
I
sir, in
mean, she
moderate
was a
PH,
thin-built lady. So these are all expected, isn't it?
yes, sir.
And middle-aged. Not that you can say, said there was a lot of lip crowding, I could not palpate.
No, no, sir.
So these are the things missing. Dr. Kamal, shall we proceed quickly to the
Yes,
investigation?
sir. Yes, sir.
Yeah.
Dikshit, you have slide X-ray ECG. Quickly go through.
Yes, sir.
Then sir can take the presentation. So read the ECG quickly.
Sir, a 12 lead ECG,
No,
Go
no,
back.
no. Go to the ECG.
Yeah.
sir, 12 lead ECG, which showing a sinus rhythm with approximately a heart rate of 75 per minute, with normal QRS axis is around plus 40. Uh, in V1, sir, in V1, V2, and V3, there is a V3 is biphasic P wave, which suggests of LA enlargement. And according to Sokolow-Lyon criteria, there is a V2 in S wave in V2 and R wave in
Is
V6.
this classical of aortic stenosis? Yes or no?
Is this ECG classical of AS? Apart from that biphasic P, or I mean, I would pass this ECG off as more or less normal.
Normal.
What is there in this ECG? Axis is normal, no STT changes.
The slight V5, V6 STD changes is there. And
Slight
according
changes,
to
no. I mean, that is.
So this may even as pass out at a left ventricular hypertrophy in a
LVH,
patient of hypertension.
yes. But sir, there is a corroborating evidence of left atrial enlargement.
That
Yes,
can be there in left ventricular hypertrophy, right? As you said, Eats from Milt or Sokolov-Lyon, you have 3 points for left atrial enlargement in hypertension. That doesn't go in favor. What would you classically expect in a patient who has a significant MS and a severe AS to be a ECG that you'll say, sir, this is two valves?
First of
Because
all,
this.
Dixit, I
Left
wouldn't
axis
expect a
division.
sinus rhythm. Atrial fibrillation is very common at this age with a combination of MS and AS. Okay. And with a left atrial enlargement, the only finding. So I wouldn't at all expect a sinus rhythm. Anyway, this may be an exceptional case.
You would expect left ventricular hypertrophy, STT changes,
Yes,
and
sir.
still have
Left.
right-sided axis. You don't have left axis. That's when you suspect it to be MS with AS, which you don't have here. You might have some amount of right ventricular forces, left ventricular forces, both present, left atrial enlargement, and axis tilting towards right rather than left would tell you it's an MS with AS. That's what you would classically expect, which is not here. Okay, just in
Yes.
case you are asked. Okay, can you quantify severity of gradient across an AS from an ECG? There is a formula. You can count all
Yes, sir.
positives and all
I think,
negatives
yes, sir.
in all the
If
12 leads, subtract it from the LV pressure. That is the gradient. That's how you get. Okay,
yes,
what is that criteria known as? Okay, go to X-ray. Read the X-ray quickly.
sir, this is a chest X-ray of PA view. showing a normal exposure and normal this X-ray showing a prominent of bronchovascular marking with normal cardiothoracic diameter with Curly's B line in
Not
the
diameter, it's a ratio, cardiothoracic ratio.
ratio. Yes, sir.
It's not a diameter, it's a ratio. It's no unit.
Yes, sir. And there is a Curly's B line in the base of the heart, sir.
Okay.
Base of the
Sure.
lung, sorry, sir. Base of the lung.
Any feature of pulmonary venous hypertension which you
Sir,
mentioned in your diagnosis?
cephalization of the pulmonary vein in upper part of the lung, sir.
Frankly speaking, I would beg to differ. In my opinion, I mean, these lung fields are absolutely normal. And anything about the left atrium, I can't see any double
Double
contour
shadow.
or
You can actually see the pulmonary bay and the even LA bay.
yeah. I mean, there is the
No
left
PH.
contour is absolutely normal. There is no straightening, no left atrial appendage,
Subcarital
and not
widening
even
is
the
also
double
not there.
contour.
LV type of apex, sir.
But you can see some aortic root dilatation. So this is post-stenotic dilatation that you can see, some amount of post-stenotic. So AS is probably you can retrospectively in hindsight you can think of. Otherwise, it doesn't. It would
I
probably
would
pass out
accept
as a
this as
normal.
a pure AS, but a combination of MS and AS, the X-ray is
Maybe.
expected to look different.
Yes. Echo?
Yes, sir.
Okay.
Please run the video.
Video, if you have sent it in inserted file, then Dikshit, I'm not sure. Okay, they are running. Thank God.
Okay, good.
Okay,
Yes,
next.
sir. This is
Click next. Next. Okay. Next.
So what have you done? Done a planimetry?
yes, sir.
And a
Did you
pH.
have a 3D picture in your echo machine?
No, sir.
I mean, would you have preferred a 3D planimetry? Okay, I mean, I appreciate your having done a 2D. What was the valve area? 1.4.
Yes, sir.
Are you happy? Could you see it? I am not very happy with the kind of.
Planimetry.
So actually, you should do a 3D planimetry. Okay,
Okay.
coming from a very tertiary high teaching center, you should do a 3D planimetry. Okay, so now you also have a AR.
Yes, sir. But
Is this from this patient?
yes, sir. But AR murmur could not be appreciable, sir.
Okay.
The envelope, I mean, at least it is mild to moderate, can't be ignored.
Can you
Sir,
play
AR
next slide?
PhD was 459 milliseconds, sir.
PhD is not, can you rely on PhD in
No,
presence
sir.
of?
No, sir.
No.
For mitral valve area
You
calculation.
have to calculate look at the vena contractor
Yes.
and look at the retrograde, I mean, the reversal of
Low.
flow in the descending thoracic aorta. Okay, other things. If
And
you
what
are
are the
able to do a
cutoffs there,
PISA, you can
Dikshit?
look at the ERO, effective regurgitant orifice area. But PhD is the first measure. Anyway, your at least AS is severe. That we appreciate. Your mean gradient is 56.
Yes, sir.
So this is by no way a low flow, low gradient, what you were saying.
No, sir. No, sir.
Okay, next slide. Okay, next slide.
It shows like a speed aortic
Next slide.
valve, sir.
Okay. Okay, go back. Go back.
So,
So Dikshit,
what is
yeah,
your plan of management?
next slide.
Sir, I would suggest this patient is symptomatic, then we will go for double wall replacement, sir. And if mitral anatomy is feasible, then we can go for AVR plus open mitral commissurotomy too, sir.
Right. Why would you do that? Why not replace both?
Sir, in DVR, there is a high chances of prosthetic heart valve thrombosis and high mortality as compared to OMC plus AVR.
Correct. Secondly, your therapeutic INRs will go down, right? Double your
Yes,
mitral, your therapeutic INR have to be higher. You'll have to keep, so that's a bigger challenge. And then you may have, when you more keep the INR higher range, you may have more bleeds. Third, do you need an angiogram for this lady?
yes, sir. Its age
Yes,
is
sir.
49 and
So
postmenopausal female. Sorry.
normally, what is the cutoff for men and what is the cutoff for women?
Uh,
So normally
for
45 and 55, that's the American guideline for a valvular heart disease. But we know from our own data sets, have you heard of any data sets from your own institute? You
40
should
years, sir.
actually be coming out whenever you have papers. How would examiner know you've done papers? So of course, it's not your paper, but it's institute's paper, Serene CAG, where we have looked at what is the incidence. You can do a CT angio, which is equally good. So you can come out with that answer. Or you can predict a predictive scoring that you can say whether the patient can be at risk. Suppose sir was asking diabetic or non-diabetic. Those things will determine whether you need an angiogram
She
or
is
not.
postmenopausal.
She is
Yes, sir.
postmenopausal. So in that case, you'll have to think about. Right.
Yes, sir.
Which valve?
Sir, mechanical valve, sir.
So somebody has told her that these days the latest model running is a tissue valve. Will you or will you not?
Sir, patient age is 49, so
She wants a
we,
tissue valve. What will you counsel her? Yes or no? She wants, I want a tissue valve, and anyway, you're not
Let
replacing
there is
Kamal, I
mitral.
will
a
be back
chance
in
of
1 minute.
Yeah.
degeneration
I'll
in
just
Sure.
within the 10 to 12 years if we can
Right.
operate with the bioprosthetic valve.
Yeah. So that degenerates quickly. That's why a prosthetic valve, metallic prosthesis is better than the aortic tissue valve. Thirdly, suppose patient says, I want TAVI, and you do mitral clip. Is it okay? Can you do a
Sir,
TAVI?
at this age, TAVI option may not be
Okay.
preferred.
Okay,
And
she's
patient,
75. You would do TAVI.
if patient is having degenerative severe calcified aortic valve,
This
then
patient is not having degenerative, right? This is rheumatic. So that should be the answer. The
no,
rheumatics don't
no,
have,
sir.
there is not enough
Rheumatic.
data for rheumatic mitral valves or aortic valves to undergo transcatheter replacement. That's what the answer should be. All right.
Yes.
So would you think of giving penicillin prophylaxis to this patient after the double valve is done?
Yes, sir. In current situation, after DVR, patient may be supplemented with injection penicillin.
Why? Both valves are already replaced. What is there to suffer from? You've already changed both the valves. What more will happen?
But again, sir, there is a chances of any rheumatic activity is there or
So rheumatic carditis, myocarditis can happen. Even tricuspid valve can get involved later on.
yes,
Even if all the three are done, then even then she can get rheumatic carditis. So that's why the penicillin prophylaxis is needed.
yes.
Suppose she was a Caucasian, do you still need to consider penicillin prophylaxis after double?
No
So in
idea, sir.
West, there are data sets that in the patients post valve replacement in the elder age group, you may discontinue. Professor Majan, your questions, if you have any questions, sir. Sir, you are muted, sir.
My question is already if the patient is having double wall replacement, then what are the problems which will face with the penicillin prophylaxis? Because you might get a hematomas also.
Yes, sir. Then oral penicillin can be given, sir.
Or
In
Or
case
what?
of patient is having on anticoagulant or patient is having AF with anticoagulant for secondary prophylaxis, sir. If
so oral penicillins are not as effective as injectables, 10 times higher recurrence rates. But yes, that's one alternative, and then you can think of other therapies like cephalosporins, or you can think of even azithromycin. Yeah.
Erythromycin,
So
yes.
I think we are running short of time. I think we should thank Dr. Dikshit. He's just second year. I think he
Yeah,
did
he
good
has a
job,
lot
and
of
I
time
did
to.
not see his slides, sir. He sent you slides. I have not seen his slides, despite being a teacher, and
No, no,
I
it's a good effort,
wanted him
Dixit.
because it's
There
good
there
to
is.
Great
do a
effort.
lot of mistakes in exams which are not real exams. So these kind of things, you should do all the mistakes, and remember the mistakes that you did today. You will surely not do that in your exams,
Yes,
because
yes, sir.
because so always remember that you don't contradict your own findings. When you say pH, four things will come in place. When you are a severity, you know how to decide, which Dr. Professor Mitra Kumar is going to say. So I think for the sake of time, Dr. Marjan and Dr. Soumitra Kumar, shall we end
Sure.
the
Shall I
presentation
share
here?
my presentation? Yeah.
Yes. So
So,
uh,
Thank you, sir. Thank you, sir.
Thank you.
thank you,
Dr.
Dixit. Well done.
Thank you. Well done. Well done.
So I invite now Professor Dr. Soumitra Kumar to do this presentation on how to decide severity, which is the dominant lesion. Like in this case, approach to decide a dominant lesion, what Dr. Dikshit was trying to do. MS and AS we were discussing. So in the next 20 odd minutes, Dr. Soumitra Kumar is going to take
So, are my
you.
slides visible?
Yes, sir. So
Okay.
Dr. Soumitra Kumar is professor and head of the Department of Cardiology at Vivekananda Institute of Medical Sciences as Kolkata. And as I said, he is also DNB Cardiology Program faculty at NHRTIICS Kolkata. Over to you, Dr. Soumitra.
Okay. Thank you, Dr. Kamal and Dr. Mahajan, for the kind invite. And it's my privilege once again to be here to present this topic, approach to decide dominant lesion in rheumatic heart disease. Now we don't have much of data with multiple valve disease. We have a lot of data with single valve diseases, but not much of data with multiple valve disease. There can be a large number of potential combinations, and each case must be considered individually. And we will not only look at the dominant valvular lesion, but we should also look at the dominant ventricle. So we can have a rheumatic etiology, congenital, degenerative, or secondary valvular lesions. Our today's focus is on rheumatic combination of valvular heart diseases. And these are the various causes which I will not delve into in the interest of time. And as I said, our interest today is only on rheumatic heart disease. And these are the various combinations. While talking of valvular combinations, we should not forget about the mixed single valve like MSMR, ASAR, things like that. And of course, we can have MSAR, ASMR, MRAR, MRTR, MSTR, things like that, and also MSTS, which is not mentioned here. And this is the data from Jayadeva Institute from Dr. Manjunath, published in Indian Heart Journal 2014 about the various frequencies of combinations in the two genders. You can see the commonest is MSMR, commonest by far in females. Next is MSAR, MRAR, third, ASAR, fourth, MRAS is fifth, and Dr. Dixit presented the least common of the combinations, that is MSAs, at least as far as this data. And I think most of you would agree that it is not very common to have rheumatic MSAs combination. Now, before I go into combination, this is a well-known thing, how to judge the severity of individual valvular lesions. It is very well known to all of you. I will not, but as you, some of the most important things are, of course, to look at the pulmonary hypertension and the consequence of that in the JVP and the right ventricular hypertrophy, the A2OS gap, and diastolic murmurs. We don't go by the intensities in any murmur, let alone the systolic and diastolic. So length of the murmur is very important, and intensity of S1. Definitely, we expect a loud S1 in severe MS, but if the valve is calcified, we can be mistaken. Then MR is also well known. Always start with symptoms, because MR has a large asymptomatic phase. When patient becomes symptomatic, it is almost always severe cardiomegaly, soft S1 and widespread S2, prominent S3, mid diastolic rumble, and the left atrial rock. What happens with MS MR? Now, MS, if the pulmonary symptoms are prominent, it is always MS which is more dominant. And with MR, we have more of easy fatigability and palpitation. With balanced, we have a mix of the two. And parasternal lift, of course, we have the classical heave in prominent AS, which is mid-systolic. But if there is an impulse at the end systole, it can be due to severe MR, as we just discussed. Now, prolonged murmur in MS, diastolic, and in MR, the murmur is not long. Predominant MR, S3 is there in predominant MR with no MS, or at most mild MS, we can have some S3 in presence of predominant MR, and S1 is loud in MS and MR soft, it is well known. So I will not waste too much of time in MS-MR because this is very often discussed, and it will be a waste of time. Severe AR, Bispherians, carotid pulse, hill sign positive, enlarged, hyperactive, laterally displaced apical impulse, diastolic MR, long, more than 2/3 of diastole, the presence of Austin Flint, and marked peripheral signs. Why am I mentioning the individual signs? Because these are modified in presence of a combination of valve lesions. So it is important to know what we get in pure severe AR and what we get even with severe AR in presence of other valvular lesions. And these are the features of severe AS. We have discussed many of this in course of today's discussion. I am not going to again discuss this. In presence of AR, what are the criteria of severe AS? Because you get a functional systolic flow murmur with pure severe AR. So whether AS is associated. If there is history of syncope, we know that AS is a high possibility. If blood pressure is truncated low, pulse volume low volume with anacrotic notch, or if bispherians with low amplitude, we know AS is often associated with AR. Apex, generally with AR, we have a grossly deviated apex, which is ill-sustained. But if we have a well-sustained apex, we can suspect a concomitant AS. Reverse splitting of S2, again, we discussed about this, presence of 5/6 or 6/6. I will not give much weightage to this, but still chances are higher that there is organic aortic stenosis with AR with this. And long systolic murmur with delayed peaking, that of course is much more important. So again, I have discussed many of this. I will not discuss. I am not discussing the ECG, X-ray, and echo part because that will need a lot of time. Echo I will discuss in greater details because these days echocardiogram has become our second stethoscope. So I will discuss that in more details. Austin Flint should not be forgotten in a case of severe isolated AR because if you are thinking of a combination of MS and AR, you should also learn to differentiate between Austin Flint and MS. So these are the ways we differentiate between Austin Flint and MS murmur. It is again very well known to you. So amyl nitrate is not well available, but this is a classical question that is asked. But what we do is a simple hand grip to find out whether it is Austin Flint and mitral stenosis murmur. Now we come to the more common other presentations that are likely to be given in the exams, a combination of AR and MS. This, as I said, is the second common combination, and palpitation is more common with AR as expected. But if you have more of dyspnea, and of course with PND orthopnea, you think of MS dominance. Embolism, of course, more common with MS, particularly if AF is there. Precordium in MS, we find a silent precordium. With AR, we have a pulsatile. And of course, pulse pressure and the peripheral signs are hallmark of AR. S1 normal and S2 normal in AR, but with MS, we have a loud S1 and loud S2, particularly loud P2. S3 with AR dominant with mild MS can be there, but it is absent in MS, of course. Opening snap is a feature of MS. And diastolic rumbling murmur, we get a long EDM in presence of MS with severe AR, but it is may not be as long. And we also get Austin Flint murmur with AR dominance, which we have to differentiate from a rheumatic MS. MS, of course, we differentiate from the long diastolic murmur with systolic accentuation. And if we have a concomitant AR, we can get a short EDM, which is better heard in the second intercostal space. MS murmur, as you know, is a highly localized murmur. Systolic murmur, we can get a ejection systolic murmur in MS because of severe PAH, but in AR, even in absence of AS, we can get a aortic systolic flow murmur. So these have to be remembered. So coming to echo, we should remember that Doppler pressure half-time method of estimation of valve area is not validated in presence of AR. Less than 130 ms PhD, we can exclude MS, but anything beyond 130, we cannot come to a conclusion. Continuity equation, we cannot use the aortic flow and mitral flow to calculate the valve area for mitral. If we want to do continuity, we have to look at the RVOT. PISA method, good for AR, for estimation of MVA estimation in MR, in the presence of AR. But the classical recommended method is 3D MVA planimetry, which I just now put across to Dr. Dixit, whether he has done it. Doppler echo is highly unreliable because AR leads to MS severity underestimation and MS leads to AR severity underestimation. So there is an overlap of the aortic flow and the mitral flow, which makes the task all the more difficult. Now coming to the next combination, MS and AR, here you know what happens because any obstruction, in the proximal valve makes the estimation of the distal valve more severe. So AR PHT, as I mentioned, is not valid. Neither MVA PHT is valid, neither AR PH pressure half time. So 3D valve area for MS estimation is very necessitated. Mitral valvotomy might wrongly delay necessary AVR, and MS restricts LV filling, blunting the effect of AR on LV volume. So we may not be getting the kind of cardiomegaly which we would get in absence of MS, despite presence of moderate to severe AR. Now, coming to the combination we discussed, MS and AS. So we have discussed many of the things. So with AS, we get a low flow, low gradient MS. With MS, we get a low flow, low gradient AS. So each one masks the other. So we are not likely to get full-blown murmurs and full-blown other auscultatory features like the S1 can be normal or slightly decreased if we have MS-AS combination. And rather P2 can be loud because there is more of pulmonary hypertension. OS can be present, but it is not as frequent as with pure MS, which I discussed. And murmur, diastolic murmur is there, but there is no presystolic accentuation if AS is associated. With AS, we'll still get a prolonged ejection systolic murmur, but again, it is likely to be shorter than with an pure AS and no MS. So that is to be remembered. So mitral valve obstruction leads to low flow, low gradient AS. What we classically get, that we get the classical signs of MS, which are dominating, but we get the physical signs of AS, which dominate. So symptoms of MS and the signs of AS. Generally, this is the kind of combination that we get when there is both significant MS and significant AS. Now, MR and AR is the other combination. What we get is a ventricular dilatation leading to increased stroke volume as a whole because the LV pumps both into the left atrium and into the aorta. So both backward and forward ejection is there. What happens ultimately that we get the same stroke volume but with less contractility. There is increased wall stress. So ultimately the LV fails earlier. With dilatation, one can keep stroke volume with less contraction force because there is always the left atrium, low pressure left atrium to fall back on, but don't underestimate the function of the LV because unless we look at the strain imaging and other modalities, we can miss out on early LV systolic dysfunction. So decreasing contractility is something we should all look forward to while assessing MR and AR combinations. In terms of clinical features, AR dominant dyspnea on exertion can be there, but with MR we get more of fatigability. PND orthopnea is often present if MR is dominant, but it still can be there with air dominance if any significant MR is associated. Pulse is classically high volume with air dominance, but MR dominance, we get high volume but less marked. Classical Hill sign, although that is a debatable thing, is there in air dominance, but not there with MR dominance. And both precordium are pulsatile with both. We get forceful ill-sustained apex with both, with a lot of cardiomegaly. And with MR dominance, we get a late systolic impulse in the left parasternal edge, the left atrial rock. Now, in terms of S1, S2, nothing very significant. S3 can be present with both. And murmur, we get a long EDM and a short MDM, the Austin Flint with air dominance. With MR, we get a pansystolic murmur conducted to the axilla, short EDM over the upper left sternal border, and mitral diastolic flow murmur due to the severe MR. And then this very grave combination of AS and MR where patient is very symptomatic. If you have a aortic valvular obstruction, you know there is more of regurgitation into the left atrium. So the LV filling pressure rises. We get a rise in left atrial pressure very quickly. We get pulmonary venous hypertension and ultimately pulmonary hypertension. And what happens to the AS? We have the forward flow which is affected. So we get a low flow, low gradient aortic stenosis. And we get many patients with early atrial fibrillation. So that is also not to be forgotten. So this is how what happens to the combination. So we have a very high incidence of dyspnea on exertion. We can get some palpitation with air dominance, but with AS dominance, not so. Syncope or near syncope often present with AS dominant, but not with MR dominant. And PND orthopnea is often an early feature with MR dominance, but a late feature with AS dominant. BP is low volume pulse with low pulse pressure, but wide pulse pressure with MR dominance. Precordial pulsation present with AS dominance because it is not as silent as in lone AS because of the concomitant presence of MR, but it is definitely more pulsatile with MR dominance. Apex is localized and heaving with AS dominant and forceful and localized ill-sustained with MR dominance. Late parasternal heave because of pulmonary hypertension and because of the left atrial rock can be there in MR dominance. And with S2, it is diminished in both, but we can get a loud P2 because of pulmonary hypertension in MR dominance. S3 is never present with AS dominance, but can be present with MR dominance. S4 with AS dominance, CS not with chronic MR. And murmur is a ejection systolic murmur classical of AS. And of course, we get a PS pansystolic murmur over the apex radiating to generally axilla with MR dominance. So this is what happens. And we look at MR, do the PISA method, ERO less than 20, no mitral valve surgery despite aortic stenosis surgery. But if we have a ERO anything between 20, 29 and more than 30, we have to find out whether it is organic MR or a functional MR. With a functional MR, if the pulmonary systolic pressure is high, left atrium is dilated and AF, we need to do something with the mitral regurgitation also. But if it is organic, we have to consider the operative risk and comorbidity. If it is low, we go for a AVR and mitral valve surgery, preferably repair. If it is intermediate, we do a isolated AVR and we look at the surgical risk, age of the patient and so on. But high risk, we go for these days, not probably for rheumatic, but we would prefer a TAVI or a percutaneous aortic valve. MSTR is the other combination, very common combination, and we always, whether we are going to do something about the TR, we'll have a look at whether it is a primary TR or a secondary TR. We look at the annular dilatation, whether competence can be restored by the left-sided surgery, or we need to do something for the tricuspid valve annulus also. So this is how we proceed. So it can be, if it is TR is severe, we need a tricuspid surgery. But if it is moderate, If it is a primary TR, again tricuspid surgery is required. If it is secondary, we look at dilated tricuspid annulus and pulmonary hypertension and then take a decision. So it is very important to find out what is not only the severity of TR, but what is the grade of pulmonary hypertension and what about the tricuspid valve annulus. TSMS, not very common, but the general rule is that the many of the features of MS are masked by the proximal stenosis, that is tricuspid stenosis. So we, despite presence of severe MS, we may not be getting that many features of MS like PND orthopnea, although I mean, it can be there in the initial part, but as again TS becomes severe, there can be absence of these features. We get more of systemic venous congestion. We get a very low volume pulse in presence of TSMS, blood pressure, low pulse pressure with both isolated MS and TSMS combination. We get a very giant kind of A wave with TSMS combination. And parasternal heave, despite presence of pulmonary hypertension, can be absent with TSMS combination. So these are some of the features, and of course, opening snap can be there, but it is less likely to be heard with TSMS combination. Tricuspid OS is very uncommon. We get a MDM because of TS at the left parasternal edge and another MDM at the apex with TSMS, but only with apical MDM without any respiratory variation in isolated MS. So I think we come to the end of the clinical part, and this is the echo part, and it's again a long thing that I will only highlight the important things, that we don't rely on pressure half-time methods in presence of AS for both AR, MS, and for MR, we will have a look at the PISA method. We'll have a look at the CMR and other methods. For MS, as I said, 3D planimetric assessment is more appropriate, and AR we can do look at the vena contracta, look at the reversal of flow in the descending aorta, and we can do a PISA if it is acceptable. With AR and other combinations, ACE, the Goldin formula and the Bernoulli equation may not be very applicable. But still we should do it. Continuity equation is applicable to assess aortic valve area if ASAR combination is there, but we have to rely on other parameters like the CT imaging to have a real look at the aortic valve in some cases. AR, MS, I've already mentioned. Again, PhD should not be applicable. We have to look at the 3D planimetry. And AR, MR, again, Doppler volumetric method using left-sided assessment of net forward flow is invalid. Mitral to aortic velocity integral ratio is also unreliable. So the PISA method remains accurate for assessment of MR in case of AR-MR combination. And again, with MS, we have to rely on dobutamine stress echo because it is a low flow, low gradient state, or aortic valve calcium scoring by MDCT. MS AR can lead to the blunting of the pulse pressure in presence of AR and LV dilatation associated with AR. So we have to again look very critically in the other features like vena contracta and reversal or Doppler reversal of flow. And with MR, we have to look at the Doppler mitral gradient because the increased gradient reflects severity of both MS and MR. And we can have a look at the PISA method to have a look at the severity of MR. The MR with AS, as I said, low flow, low gradient AS is common with presence of MR. So again, we have to rely on DAC or MDCT calcium scoring. MR, AR, already I've highlighted that with regard to MR, I'm not going to. CMR remains a very useful tool in assessing AR-MR combination, and MR-MS also I have discussed. These are the tips and tricks. We have to rely these days more on advanced methods of imaging, the MDCT, CMR, and the advanced modes of echocardiography, the 3D echocardiography for Doppler, both 3D, TE especially, for planimetric assessment of not only mitral valve area, but also the aortic valve area. So this is calcium scoring with CT, and more specific, as you know, the ESC guidelines for ladies, it is anything more than 1200, and for men, anything more than 2000 is taken to be severe. Some of these cases, I mean, just quickly I'll say, and this is one case where there is eccentric MR, and you can see there is a severe AS, but it is a classically a low flow, low gradient AS, at least partially because of the MR, but still from the calcium score, we can find out that this is a very severe AS. So this gentleman actually had a degenerative aortic valve disease, but he underwent TAVI, but the mitral valve was untouched. And you can see the mitral valve MR severity has not increased even after TAVI. So that is why it is important to decide on the dominant lesion. But this case, our DVR is the only way out because we can see both MS, MR, ASAR, and from planimetry, we can see there is severe mitral stenosis. So this patient has to undergo a double valve replacement. This is another case where we have a combination of various lesions. So we have MS, which is severe. We have some AR, but this patient underwent a mitral valve replacement, but the AR was untouched. And because the AR by vena contracta was only 0.4 centimeters, so nothing was done to the AR. And even after mitral valve replacement, the severity of AR did not increase, so it was the right kind of judgment. This is one case where we need to do a lot of things. So we can see that this patient has AS-AR, and this patient also had a severe mitral regurgitation, and this patient also has a tricuspid regurgitation with high velocity and some degree of tricuspid annular dilatation. So ultimately, patient underwent a triple valve replacement. And so something had to be done with the mitral valve, something had to be done with the aortic valve, and also the tricuspid valve had to undergo ring annuloplasty. So these are the judgments that we have to make when coming to a decision. CMR, in particular, when echo is inconclusive on the severity of regurgitant lesions, is very, very useful. So particularly for the degree of MR and AR these days. And this is a very good paper. I mean, it is coming to be useful for stenotic lesions also. So days are not far away where we can assess the planimetric assessment of aortic stenosis. And from T1 weighted imaging, we can also have at the degree of fibrosis of the left ventricular myocardium in a case of aortic stenosis. And we can always, of course, assess the degree of regurgitation. This striped area shows with time the amount of regurgitation. So CMR is coming up in a big way also to find out the relative severity of complex valvular lesions. So this is how we come to a decision. In the interest of time, I will run through them. We have a lot of guidelines, the ACC AHA 2014-17 guidelines and 2017 guidelines with regard to this combination of lesions. So when the lesions are severe, probably we'll have to tackle all the lesions together. But you can, my dear students, you can refer to these guidelines in the interest of time. I will not go into the details, but when the lesions are less severe, there comes our clinical expertise as to which lesion is more severe, whether we need to tackle both or we can leave one lesion just to make the procedure less complicated and just to make the later part of the life post-operative. That is, we should always remember that a patient with a prosthetic valve doesn't necessarily have a normal heart. He also has another kind of disease, the prosthetic valve disease. So we should not be, replacing valves rampantly. So that is something to be kept in mind. And actually, we need a heart valve team consideration to decide on the proper approach. And these are the various things which should be borne in mind. So the kind of valve lesions, the two ventricles into question, the degree of pulmonary hypertension, what is the anticipated progression of a secondary valve lesion if left untreated, and times are coming when at least some lesions are going to be treated by transcatheter options. We are already there. We are progressing faster with this. Stage procedures versus all at once treatment should be considered. The procedural risk, the local experience of the treatment team, and of course, the wishes of the patient and the family. So to conclude, ladies and gentlemen, multiple and mixed valvular heart disease are highly prevalent. Rheumatic heart disease remains the most prevalent pathogenesis in developing countries. Hemodynamic interactions may alter the clinical expression of each singular lesion, and the clinician should be aware of these interactions that may impact the diagnosis. A case-by-case therapeutic management strategy should be made by a heart valve team taking into account multiple factors, including the severity of each single valve lesion, the individual risk profile, the increased long-term morbidity of multiple processes, and the natural history of each valvular lesion if left untreated. Current and future advances in transcatheter valve therapies are likely to change the therapeutic approach of multiple valvular heart disease, but there is currently no evidence-based management strategy in this setting. Particularly, we don't have much of transcatheter procedures now approved for rheumatic heart disease. Of course, mitral valve interventions are going to be more rampant in days to come. Thank you very much for your patient hearing.
Thank you, Professor Soumitra Kumar. It was wonderful talk and beautifully elucidated how multivalvular case needs to be approached. And we had a discussion as to how he's going to take this through. And he was very imperative about not only integrating just the clinical science, which he did very beautifully in multiple tables and charts, but also how echocardiography and modern investigation are important when to approach a multivalvular heart disease in terms of the clinical case scenarios that also you should. Thank you very much, sir, for wonderful
My
presentation.
pleasure.
It was lovely to have you. So this will bring an end to today's discussion and meeting. We have overshot time, but this was the first day of the series of 8 lectures that have been planned. Can we have the slide and the schedule for the next time, RX events, so that our rest of the audience can see as to how this program is going to roll? So our next presentation on this clinical cardio class is going to be, the case presenter is going to be Dr. Kriti Kori from KEM and Dr. Rakesh Yadav from AIMS, Professor Cardiology, is going to take us through a topic of evaluation of arrhythmic risk in LVOT. Dr. Rakesh Yadav specializes in EP as well. So he is going to be evaluating that. And this is on 26th of September. Remember, it's going to be Thursday always. So it's going to be, if you're missing it out, just don't remember the dates, then it's Thursday always. You can get in touch with the organizing team and committee. And it's all going to be 8 p.m., but not consecutive one. And this is the schedule. You can take a snapshot, which is planned for the next time. So thank you very much, Dr. Soumitra Kumar, sir. I think it's very important that in the case of multivalvular heart disease, important things are clinical diagnosis. It starts right from history, as I was mentioning. Yeah, also assessment of apex beat, JVP, pulse, murmur duration, blood pressure, and symptomatology duration, ODP and HOPE is going to tell you what is dominant lesion, which again can be substantiated by ECG and X-ray by dominance of the ventricle and the pressure. And again, as sir has shown, sometimes what looks clinically not so significant may be significant on assessment on echo or otherwise imaging modalities, and is going to change. What looks severe may not be the case like he showed in a case of aortic stenosis and MR. So it's thank you from my side, Dr. Ajay Madan, sir. Over to you. And then we have Dr. Bhagirat Solanki, who is Secretary of IACM also. And then we can have closing comments from
So it is one of the most excellent presentation. It was a excellent effort by PG student, and Dr. Soumitra Kumar sir was a very elaborative in his lecture for how to diagnose the severity of the valvular heart disease depending upon the clinical. And the most important thing is the echocardiography, because we have to concentrate on echocardiography to take all the decisions. Every time you should not take the decisions on CAT table, but echo is the one of the most important investigations. So echo Doppler is the most important investigation for cardiologists to come to the conclusion for the surgical interventions or any intervention in multivalvular heart disease and to understand the hemodynamics and understand the adequacy of the medical management. So that thing is taken care by Dr. Soumitra Kumar. So thank you, Dr. Soumitra Kumar. Thank you, Dr. Kamal Sharma sir and other panel members for this particular excellent session. Thank you.
Soumitra Kumar.
Thank you. I mean, it was an excellent experience from my side, interacting with students and my learned colleagues here. So it was a learning session for me as well, and a pleasure at the same time. And please continue the endeavor. In fact, as member of the audience, I would like to log in whenever it is possible from me. I mean, it is excellent endeavor, and again, heartfelt congratulations to all the people involved. Dr. Kamal, Dr. Mahajan, Dr. Solanki, and of course the event managers and the team of AstraZeneca. I think they have taken this initiative. Thank you very much.
Thank you, sir. Dr. Solanki, vote of thanks, and then we can close.
Yes, yes. Thank you, Dr. Kamal Sharma, for giving such a wonderful platform for discussion of clinical cases and integrating the eco and then discussing about the management. It's a very good opportunity for the super specialty students. I am really thankful to Dr. Dikshit, who has presented from UN Mehta as a R2 in cardiology, then Dr. Soumitra Kumar, Dr. Anil Kulsrestha, our other panelists, the R
And we'll probably have a network issue with them. Thank you very much. So good night from our side.
Good night.
Take care. Bye-bye.
Thank you, sir. Thank you. Good night.
Indian Association of Clinical Medicine Gujarat chapter is very glad to associate with you, and we'll continue our endeavor in future. Thank you.
Thank you. Thank you.
Thank you.
Thank you.